The Epilepsy Foundation is pleased to bring to you the first of 3 modules in an education series titled Seizures and Epilepsy in Older Adults. This series of learning is brought to you with support from Synovian. My name is Dr. Elaine Kyriakopoulos, and I would like to extend a warm welcome to everyone who has joined us today. I'd like to share with you the mission of the Epilepsy Foundation. The mission of the Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. The Epilepsy Foundation and our partners are also committed to working to ensure that older adults living with epilepsy received the best care possible to improve health outcomes and quality of life. I'd like to review with you the format for today's webinar. Throughout the presentation, all phone lines will be muted. However, we'd like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel on the right and click Send. We will read your questions aloud and address them during the question and answer portion of the webinar. Please keep your questions general in nature, as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. This webinar will be recorded and available for viewing and listening on epilepsy.com. I am so pleased and honored to introduce to you Dr. Alice Lamb. Dr. Lamb obtained her MD and PhD degrees from the University of Michigan Medical School. She trained in neurology at the Partners Neurology Residency Program at MGH and the Brigham and Women's Hospital and obtained her subspecialty training in clinical neurophysiology and epilepsy at the Massachusetts General Hospital. Dr. Lamb is currently an epileptologist and clinical neurophysiologist at the Massachusetts General Hospital and an assistant professor of neurology at Harvard Medical School. Her translational research program focuses on the intersection between epilepsy and the neurodegenerative diseases. As a physician, she sees patients in both the epilepsy clinic as well as the memory disorders clinic at MGH. Dr. Lamb has been a steadfast supporter of the work of the Epilepsy Foundation at the local level with the Epilepsy Foundation New England and at the National Foundation level, and we are grateful for her time and expertise today. Welcome, Alice.
Thanks, Elaine.
There are no speaker disclosures for today's webinar. Today's webinar, Module 1 of the 3-part series, will focus on seizure identification and epilepsy basics. We will provide for you today a review of seizures and the basics of epilepsy, a review of the epidemiology of epilepsy in older adults. We'll take a look at common seizure types and those most often seen in older adults. Dr. Lamb will describe for you seizure signs and symptoms in older adults and help you to better understand risk factors for epilepsy in older adults. We will also take time to review seizure first aid as a group. At this time, I'm going to turn things over to Dr. Lamb, and thanks to everyone for joining us and for your attention.
Thanks for the very kind introduction, Elaine, and thanks everyone for joining us. It's a real pleasure to get the chance to speak to you all today and to give the first talk in this webinar series on seizures and epilepsy in older adults. I'd like to start off by giving you an overview of the brain, seizures, and epilepsy. So the human brain is an incredibly complex and dynamic structure. It's made up of billions of cells called neurons. And these neurons communicate with each other by sending and receiving messages in the form of electrical impulses. The electrical activity in the brain is normally very carefully balanced, but seizures occur when there is abnormal and excessive electrical activity that temporarily disrupts brain function. So every brain has the potential to seize. When I talk to my patients about seizures, I often tell them to think of seizures as an electrical storm that's happening in their brain. And the graphic that you see on the background of the slide shows an EEG recording of the brain's electrical activity over time. And each horizontal line represents electrical activity occurring over a different part of the brain. And on the far left of the screen here, you can see what looks like, relatively normal brain electrical activity. But about a quarter of the way in, you can see my mouse here, you can see a very clear change in the pattern of the electrical activity over time. And this is the start of a seizure. This is the electrical storm that's happening. Seizures can wreak havoc on the brain's normal function. They can cause changes in a person's movement, speech, behavior, and even awareness that really aren't under that person's control. It's important to know that seizures are incredibly common. So 1 in 10 people will experience a seizure at some point in their lifetime. So what does a seizure look like? Most people think that seizures are, big events where someone falls to the ground and their whole body shakes and they foam at the mouth. And that's how seizures are typically portrayed on TV or in the movies. But it turns out that seizures can be much more subtle than that, and they can take on many different flavors. As I mentioned in the last slide, I think it's helpful to think of seizures as electrical storms in the brain. Now, these electrical storms can affect different parts of the brain for different people. They can affect a very small portion of the brain, or they can affect the whole brain all at once. And where in the brain these electrical storms are happening and how much of the brain is involved will dictate what kinds of symptoms someone will experience during their seizure. So that said, some seizures can look like staring spells where someone just zones out momentarily. Some seizures can be a brief muscle twitch or spasm. Other seizures might present as difficulty speaking, or someone becoming confused, or someone making unusual chewing movements with their mouth or picking at things with their hands. People can get up and wander during a seizure, or they might feel very unsteady during a seizure. More severe seizures can cause a person to collapse, shake, and become unaware. But it's important to know that there are other seizures that can be extremely subtle, and they can have very few outward signs. The person experiencing the seizure may just notice a funny feeling, or they might experience an unusual smell of something that's not actually there. And it's not uncommon for these types of subtle seizures to go unrecognized, because a lot of people just don't recognize that subtle symptoms like this can actually be part of a seizure. One other important point I want to make is that even though the signs and symptoms of seizures can vary from person to person, in most cases, the kinds of seizures that any given individual will experience are typically consistent and predictable for that person. So if a person's seizures consist of experiencing a funny smell and then feeling confused, typically all of that person's seizures will present just like that. Not everyone who's had a seizure has epilepsy. It's important to make the distinction between seizures and epilepsy. So just because someone has had a seizure does not necessarily mean that they have epilepsy. Sometimes seizures can be caused by certain medical conditions or by certain medications. And in approximately 50% of the seizures that occur in older adults, there's not a clear cause. What does it mean for someone to have a diagnosis of epilepsy, and how is that different from having had a seizure? So diagnosis of epilepsy means that a person is at risk for having recurrent or more seizures in the future. Having a diagnosis of epilepsy, it doesn't tell you anything about what the cause of someone's seizures is or what that person's prognosis is. And there are many different types of epilepsy, and epilepsy can affect people in many different ways. Some people have epilepsy that's really well controlled on medications, and as long as they take their medications, they can stay seizure-free and pretty much have a normal life. But then there are other people whose seizures don't respond to medications, and they'll continue to have seizures. And in some cases, these seizures might be relatively minor, and they might not affect someone's day-to-day function that much. In other cases, having uncontrolled seizures can be extremely debilitating, and it can be the cause of many bodily injuries. It can make it impossible for someone to be able to keep a job, drive a car, take care of themselves or their families. So there's a very broad spectrum of impact that epilepsy can have on people. You'll often hear people refer to epilepsy as a seizure disorder. They both mean the same thing. They both mean that someone is at risk for recurrent seizures. In the past, a diagnosis of epilepsy was made after someone had 2 or more unprovoked seizures that occurred more than 24 hours apart. We've since revised this definition. The old definition still holds. So if you've had 2 or more unprovoked seizures over 24 hours apart, you would still have a diagnosis of epilepsy. But now we can also make a diagnosis of epilepsy if someone's only had 1 seizure, but there's clear evidence that they're at high risk of having more seizures in the future. For example, if someone were to have 1 seizure, but their EEG study showed a clear electrical abnormality, or their brain imaging showed a clear structural lesion, then they could still be diagnosed as having epilepsy because of the increased risk that they have for having more seizures in the future. Our new definition of epilepsy also includes that if a person's been diagnosed with a certain syndrome that we know includes seizures as part of the syndrome, even if they've only had 1 seizure, they can still be formally diagnosed as having epilepsy. So let's talk about who has epilepsy. Epilepsy can affect anyone. It affects people of all ages, from newborns all the way to the very elderly. It affects people of all races, all socioeconomic classes, and all geographic locales. Epilepsy is extremely common. It's what I'd consider a hidden disease, though. People with epilepsy often don't share the fact that they have epilepsy because, unfortunately, there's still a lot of misinformation and stigma that surrounds this diagnosis. But it turns out that 1 in 26 people will develop epilepsy at some point during their lifetime. Think about the size of your graduating high school class. My high school class was about 450 kids. So that means somewhere between 50 to 20 people from my high school class will be affected by epilepsy at some point in their lives. This is a very common disease, so it's important to know about it. In the US, there are 3.4 million people who have epilepsy, and worldwide, it's estimated that there's about 65 million people who have epilepsy. Epilepsy is really common in older adults as well. In fact, aside from very young children, older adults are the most common group of people to be affected by epilepsy. Nationwide, there's close to 1 million older adults, people over age 55, who report active epilepsy. And the incidence of seizures and epilepsy increases as people get older. So every year, there are more than 50,000 new cases of epilepsy in people above the age of 60. And in 1 out of 2 older adults, the cause of their epilepsy is unknown. Let's talk a little bit about what we know can cause epilepsy in older adults and how we go about evaluating and treating epilepsy in older adults. This is a list of the most common causes of seizures in older adults. You can see that stroke is by far the most common cause of seizures in this population, accounts for up to half the cases with known etiology. And the next most common cause is brain tumors. That accounts for about 10 to 30% of new onset seizures in older adults. And then coming in third is neurodegenerative diseases, the most common of which is Alzheimer's disease. And there are a variety of other causes of seizures to think about as well in older adults. Certain metabolic disorders, for example, hypoglycemia or hyponatremia, can cause seizures in older adults. These metabolic disorders are typically related to complex medical problems, or they can be related to side effects of medications, as a lot of older adults are taking a lot of medications. Alcohol withdrawal can cause seizures in older adults. Infections can also cause seizures. And head trauma is another important one to think about. The most common cause of head trauma in older adults is falls, actually, where someone might hit their head and develop bleeding in the brain or some other injury of the brain that will cause seizures. So now that we know what seizures are and what can cause them in older adults, let's talk about how we'd go about evaluating someone for seizures. The most important thing is to get a good medical history and to get a really good description of the event, what happened. It's important to note that the person who's having the seizure can actually experience this very differently from what people around them actually observe them to be doing. So while I always ask the person who had the event to describe what they experienced, it's just as important, sometimes even more important, to ask the people who were there and who witnessed the event to also describe what they saw. The kinds of questions I'll ask was, what was the person doing right before the event happened? What kinds of symptoms did they experience during the event? Did they become confused or unresponsive? Were they able to talk coherently during the event, or were they speaking gibberish? Were they doing anything in particular with their arms or their legs? Was their body totally stiff, or was it limp? How long did the event last? Did the person remember the event afterwards? Was the person confused afterwards, or did they return to being back to themselves right away? Was this the first time they ever had these symptoms, or have they been having repeated episodes of these same symptoms over time? And was there anything they could think of that triggered the event? For example, a change in medications or an illness at the time, maybe drinking too much alcohol, things like that. And a lot of the time, with just this information, an epilepsy doctor will have a pretty good sense of whether they think this person has had a seizure or not. After that, we'll do a medical and neurological exam and blood tests and other diagnostic tests, usually an EEG or an electroencephalogram, as well as an MRI of the brain. Sometimes we'll also include cardiovascular testing or autonomic testing. And there's multiple goals for all of this testing, for this whole evaluation. First, we want to look for an underlying cause for the seizure. Did the person have a stroke? Do they have a brain tumor? Is their blood glucose or sodium level too low? Second, we want to rule out potential seizure mimics. For example, someone might have a heart rhythm abnormality that causes them to lose consciousness and shake a little bit. And sometimes this can look very similar to a seizure. But the treatment for a heart problem is obviously very different from the treatment for a seizure. So we want to make sure we have the right diagnosis. And third, we want to determine whether this person is at high risk for recurrent seizures in the future. In other words, do they have a diagnosis of epilepsy? Once we've diagnosed someone as having epilepsy, what treatments are available to help this person? The first line of therapy is anti-seizure medications. There are many different medications to choose from. There's over 30, in fact, medications you can choose from. And there are multiple things to consider when choosing an anti-seizure medication for a patient. You'll hear a lot more about this in next week's webinar. Overall, medications work pretty well, though. 2 out of 3 people with epilepsy can be seizure-free by taking medications. Now, of course, that means that 1 in 3 people with epilepsy will not be seizure-free with medications alone. And in these people, we often will consider other treatment strategies. This might include epilepsy surgery or neuromodulation, for instance, with brain stimulation devices. We know that certain types of diets, such as the ketogenic diet, can reduce seizures in some people. And then there are other investigational medications that we can try. We've talked a fair amount about the basics of seizures and epilepsy, and now I'd like to spend a little more time giving you an overview of how seizures are classified and what the most common types of seizures are. There are different characteristics of seizures that we pay attention to when we classify seizures. The first way of classifying seizures is based on where the seizure starts, or really how much of the brain is involved at the very beginning of, or at the onset of the seizure. Sometimes seizures can start in just a small region of the brain, as you see here, and we refer to these seizures as focal onset seizures. Other seizures can involve the entire brain all at once at the beginning of the seizure, and we refer to these as generalized onset seizures. Sometimes it can be really difficult to tell for sure whether a seizure has a focal onset or a generalized onset, and so those end up being classified as having an unknown onset. I should point out that some seizures can start out as focal onset seizures. They start out in just part of the brain, but over the course of that seizure, it can spread to involve the entire brain. And we'll often call these focal onset seizures with secondary generalization. The other important features that we use to classify seizures are, first, whether or not someone's level of awareness is affected during a seizure. Some seizures involve maintained awareness, meaning that a person's fully aware of everything that's going on around them during the seizure. They know exactly what people are saying to them. They know that they're having a seizure. Their thinking's essentially normal. Other seizures involve impaired awareness, and that means that someone's thinking is not quite normal during a seizure. This can range from being just a little confused during the seizure to being partially aware of what's going on but unresponsive. And in some cases, people may completely black out and have absolutely no recollection of what happened to them during the seizure. So that's aware and impaired awareness seizures. And we can also classify seizures based on whether they involve movements of the body and what kind of movements are involved. Seizures that involve movements are called motor seizures, and those that don't involve movements are called non-motor seizures. To put all that together, that was a lot of information, I know, but to put that all together, there's this classification scheme here that's shown. This is a scheme that was developed and published by the International League Against Epilepsy in 2017. And you can see how the information that we talked about on the last slide fits into this classification scheme. Again, it really highlights that seizures are classified by their onset, where they start, how much of the brain is involved when they start, whether they impact someone's awareness, and whether they involve movements or motor symptoms. So let's take a look at this first column here, focal seizures. These can present with or without someone's awareness being affected. And they can also have motor symptoms that are affected with a seizure. As I mentioned in the last slide, any seizure that starts in one area of the brain can spread to involve the entire brain. And here they refer to this as a focal to bilateral tonic-clonic seizure. Under the second column, you can see the generalized onset seizures. These almost always involve impaired awareness because the entire brain is impacted all at once. Generalized onset seizures can have a variety of motor symptoms. Probably the most well-known type is what's called a generalized tonic-clonic seizure, or a GTC for short. Sometimes you'll hear people use older terms like grand mal seizure or convulsion to refer to these generalized tonic-clonic seizures. And there's also generalized seizures that are non-motor seizures. And one example of that is called an absence seizure. You might hear people refer to absence seizures by the older name for them, which was petit mal seizures. These seizures can be associated with staring spells. Particularly, they occur most often in children. You might be asking, why is it so important to know how to classify a seizure? Well, it's important because it really helps determine what kind of a medical evaluation a person should have. And it helps medical teams determine what the most appropriate medications might be for a given individual. I want to spend a little more time now talking about what seizures can look like to an observer. I think this is so important because the more healthcare professionals who understand this and who can recognize when a person's having a seizure, the more likely it is that people with epilepsy can be diagnosed in a timely manner and that they can be started on appropriate treatments to help stop their seizures. So let's start with focal aware seizures. With this type of seizure, a person, as we talked about, remains fully aware of what's going on around them. These seizures can involve all sorts of different symptoms, though. They might involve motor symptoms. For example, a person might have twitching of one side of the face. They might have rhythmic shaking of an arm or a leg. They might even have stiffening of an arm or a leg that's not under their control. Other seizures, other focal aware seizures, can involve sensory symptoms. Someone might have tingling or numbness on one side of their body. They might hear a certain sound or a song. Sometimes people can smell something that's not there. Usually this tends to be an unpleasant smell, like burnt cigarettes, burning rubber, sulfur, or cheap perfume. Sometimes people will get an unusual taste in their mouth. They might describe a metallic taste, almost like they were chewing on a penny, something like that. Other people can feel sick to their stomach, or they might feel nauseous. People can get visual distortions during these kinds of seizures. For example, people might see flashing lights or different shapes or colors that aren't actually there. And then there are what we call psychic symptoms that people can have during a focal aware seizure. This can be a feeling of déjà vu. That's a strong, sudden feeling of familiarity, like you've somehow experienced the same moment before in time. Other people might have hallucinations. We talked about smelling things that aren't there, tasting things that aren't there, seeing things that aren't there. And there's people who might have a sudden feeling of fear or anxiety that comes out for no clear reason. You might see that often this can be diagnosed as them having a panic attack when actually it's a seizure. And a lot of times patients will tell me, I just get a really weird feeling that I can't describe. It can be really hard for people to describe what it feels like, but that can be part of a seizure. And as you can see, the symptoms that go along with focal aware seizures, they can be so subtle that really only the person who's experiencing the seizure is even aware that there's something unusual going on. Typically, these seizures are short. They last less than a minute. But again, because these symptoms are not always so easy to define, and because many of them don't have a clear outward sign or symptom, these seizures can often be confused with psychosomatic illness. They might be misinterpreted as being some sort of a mystical or religious experience, and they might be confused, by other people as being due to illicit drug use. So those are focal aware seizures. Let's next talk about focal seizures where a person's awareness is impaired. So this type of seizure, it often begins with a blank stare and a person becoming unresponsive. So people who are witnessing this, they'll often say it's like the lights were on, but no one was home. The staring, it can be accompanied by automatic movements that are repetitive and purposeless. These movements can seem clumsy or disoriented. They might involve a person walking aimlessly, wandering aimlessly. Other people might pick at things with their hands. You might see people picking repetitively at their clothes in a purposeless manner. They might pick at their sheets if they're lying in bed. People might say things that don't make sense. They might have unusual repetitive mouth or lip movements. Often this is described as lip smacking or chewing movements, or repetitive licking of their lips. And after a focal impaired awareness seizure, a person will often feel really tired afterwards, and they'll want to sleep, often for a few hours afterwards. Some people can be really confused after having this kind of seizure, and they can become combative if you try to restrain them in that setting. It's not unusual for people to develop a headache or nausea after this kind of seizure as well. Focal impaired awareness seizures, they usually last between 1 to 3 minutes. And because of the impaired awareness and confusion and the unusual movements that people might have, these kinds of seizures can often be confused with substance abuse. And as I said, aggressive behavior can arise if you try to restrain someone having this kind of a seizure. So I've had patients who are, good law-abiding citizens who've gotten into trouble with police after having a focal impaired awareness seizure, either because they were acting so unusually or because they were very aggressive when someone tried to restrain them. And unfortunately, at that time, no one recognized that that person was actually having a seizure. So I want to highlight some of the challenges that are involved with focal seizures. Again, because most people think of seizures as being big convulsive events, often the symptoms of focal seizures can go unrecognized and untreated. Particularly in older adults, symptoms of focal seizures can be misinterpreted as just being part of aging, or they might be mistakenly linked to other medical disorders. Focal seizures with impaired awareness can be really tricky because people may not be totally aware that they're even having these events. And that can make it really difficult for them to be diagnosed with epilepsy and to get proper treatment. It may not actually be until someone else, maybe it's a family member or a coworker, observes them having this event that it's brought to medical attention. All right, we've been talking about focal seizures. Let's switch to talking about generalized seizures. One type of generalized seizure that we've talked about before is the generalized tonic-clonic seizure. Again, this is the typical seizure type that comes to mind for most people when they think about someone having a seizure. Generalized tonic-clonic seizures, or GTCs, they'll often begin with a sudden hoarse cry. What happens is the chest muscles contract, and that forces air out of the person's lungs, and the air rushes past their vocal cords, and that's what causes this cry. Sometimes it can sound more like a scream. And after that, the person's arms and legs will stiffen. This is what's called the tonic phase of the seizure. If they're standing during this phase, they'll often fall to the ground during the tonic phase of the seizure. And after the tonic phase comes what we call the clonic phase. This is where a person's arms or legs will jerk or twitch rhythmically. After a few minutes of that, the jerking will slow down and then stop. During a GTC seizure, the person may have very shallow breathing, or they may drool. They can lose control of their bladder or of their bowels. Sometimes their skin, their nails, or their lips might turn blue. And afterwards, the person's often very confused and very tired. Their muscles are often very sore. They feel like they've just run a marathon, essentially. And they might have a headache, or they might have transient difficulty with speech. GTC seizures, they typically last about 1 to 3 minutes. But for people who are observing the event, it can feel like it lasts much, much longer than that, because it can look very scary to someone who's never seen one before. Let's talk about some of the challenges of these GTC seizures. These seizures, as I said, are pretty violent events, and they can cause significant physical injuries. People can get injured from falling. Again, they're not aware when they fall, and so they don't even try to catch themselves when they fall. They can break bones or vertebrae. They can dislocate joints. They might suffer significant head injuries when they fall, and they can have muscle and soft tissue injuries. Particularly in older adults who might already be in a frailer medical condition, it can take a really long time to recover from a GTC seizure. People are often hospitalized after having a GTC seizure, and there can be other complications from being hospitalized. And then there's a whole host of other safety issues to think about. If someone's had a GTC seizure, for instance, while they're cooking, they could easily burn or scald themselves. If they have a GTC seizure while they're swimming, they could easily drown. People with GTC seizures, they really shouldn't be taking baths on their own, because it's actually possible to drown in a bathtub, even though the water is pretty shallow. It's possible to drown in a bathtub during these seizures. So there's a lot of safety issues that go along with GTC seizures. Now that we've reviewed the different symptoms that can occur with seizures, I just wanted to put this slide here to remind you again of which older adults are at high risk for developing seizures. Again, older adults who have had a stroke have the highest risk of seizures. In fact, their risk is 20 times higher than the risk of a healthy older adult who hasn't had a stroke. Dementia is associated with a 5 to 10 times increased risk of seizures. And depression is also associated with a 6 times increased risk of seizure. Trauma, alcohol, and infection are all associated with a 3-fold increased risk of seizures. All right, so we've discussed a lot of the basics on seizures and epilepsy. Let's try to bring it all together now. Again, one of the things that I really hope you take away from this webinar is to be able to recognize symptoms that might indicate that someone's having seizures. This is a list of the different signs and symptoms that people who've experienced a seizure or their family members might bring to their healthcare providers as something that they're worried about, something that they thought was a bit unusual. And again, patients or their family members often may not recognize that these symptoms are related to seizures. But knowing what you know now, my hope is that you might be able to recognize the symptoms that are listed here as something that could potentially be caused by seizures. We've talked probably about most of these different symptoms that are listed here. Now, the list of symptoms that I showed you on that last slide and all the symptoms that we've talked about that can occur during seizures, these are symptoms that can certainly occur during seizures, but as you can imagine, these same symptoms could also be caused by a lot of other medical conditions. And I've listed some of those here for you to look at. It's really important to consider and to rule out these other possibilities. Again, because the treatments for these other medical conditions will be very different than the treatments for seizures. So we want to make sure we get the diagnosis correct. And we've talked a lot about different types of seizures, but here's a list of the most common types of seizures that occur in older adults. As you can see, the majority of seizures that occur in older adults are focal impaired awareness seizures. And as we've discussed, these are challenging because these are some of the most difficult types of seizures for people to recognize. I want to touch on some of the public misperceptions about epilepsy. There are a lot of these misperceptions, and these misperceptions can impact not only whether someone might seek care for their epilepsy, but also how that person may be treated when other people find out that they have epilepsy. So people can often be in denial that they have epilepsy, or they might ignore signs and symptoms of seizures because they're in denial about having epilepsy. There's a lot of stigma surrounding this diagnosis, that it causes aggressive behavior, that it causes undue burden on family and society, that it might make a person less able, that it's a disease primarily of the young and not of the elderly, and that it will unnecessarily limit someone's independence. It's just so important that we recognize these misperceptions and that we continue to raise awareness about epilepsy, this hidden disease. And it's really important that we treat people with epilepsy with compassion and with understanding. Okay, so now that you know how to recognize a seizure and you know what causes seizures, I'd like to finish up the webinar by teaching you some seizure first aid. How can you help someone when you realize that they're having a seizure right in front of you? The three basic principles of seizure first aid include 1, staying with the person, 2, keeping the person safe, and 3, in the appropriate circumstances, turning a person on their side. Stay safe and side. These are good guidelines for thinking about seizure first aid. The other concept that I want you to remember is the idea that it's really important to time a seizure. And I want you to remember the critical number of 5 minutes as a guide for your response during a seizure. So let's walk through what you can do if you happen to be present when someone's having a seizure. Now that there's many different types of seizures, and clearly you'll end up tailoring your response appropriately based on what kind of a seizure someone's having. But there are common principles that apply. So step 1, if you're present when a person's experiencing a seizure, you want to stay with that person. If they're having a generalized convulsion, as I mentioned before, it can be pretty scary to watch if you've never seen one before. But it's really important to remain calm and to try to keep those around you calm. check for a medical ID to see if this person has a diagnosis of epilepsy already. And as soon as you recognize that they're having a seizure, use your watch or your phone to start timing the seizure. Step 2, you're going to want to keep the person safe. So you should move harmful or sharp, hard objects out of the way so that the person doesn't hurt themselves while they're shaking, if they're shaking and unconscious. Or if the person is wandering aimlessly during their seizure, you want to try to gently guide them away from any dangerous situation. For instance, if they're about to walk into oncoming traffic, guide them away from that. Or if they're, going to walk onto terrain that's rocky or uneven where they could easily fall and injure themselves, guide them away from that. If a person loses consciousness, if possible, gently guide them to the floor or ground if you can. That can be difficult sometimes, though. Step 3, you want to turn the person on their side. This helps to make sure, this is particularly if they've fallen onto the ground, this helps to make sure that they don't choke on their saliva during the seizure, and it helps to keep their airway open. You can put something soft like a jacket or a sweatshirt or a pillow under their head, and you should loosen any tight clothing like ties or scarves, or if they have like a button-up shirt with a collar, unbutton the buttons there, but just to make sure that there's nothing constricting their neck during the seizure. Step 4, never put anything in someone's mouth when they're having a seizure. Again, this is a big public misperception that you should put something in the mouth to, prevent them from biting their tongue or prevent them from swallowing their tongue. But really, you should never put anything into someone's mouth if they're having a seizure. Don't offer them food or medication until they're completely awake and aware and back to themselves. Step 5, you don't want to restrain a person during a seizure. So holding someone down during a seizure will not stop the movements that accompany a seizure. Those movements will stop when the seizure ends. And as we've talked about, most seizures last, between several seconds to a few minutes at most. Don't hold them down. In fact, this can sometimes cause further injury if you do this. So please don't do that. Step 6, after the seizure is over, you should stay with the person until they're fully awake and aware. Remember that often people will come out of these seizures extremely confused as to what just happened. They may not realize what's just happened. So you can offer them reassuring words, let them know in very simple terms what happened, and tell them that they're okay. And you can offer to call one of their family members, friends, to help them return home safely if this is someone that you don't know. Most seizures are not medical emergencies, but there are instances where you should definitely call 911. These are listed at the very bottom of the slide. If a seizure lasts longer than 5 minutes, and remember you're timed it as soon as you recognize that happening. If it lasts longer than 5 minutes, or if a person has repeated seizures, you should definitely call 911. These are signs that a person's body may not be able to stop the seizure on their own, and that person may need stronger medications to help stop the seizure. If the person's having any difficulty with breathing, or if the seizures occurred while the person was in water and they may have choked on water, swallowed water, you should call 911. If the person is injured during the seizure, or if they're pregnant or in medical distress, call 911. If a person doesn't return to their usual state after a seizure, it's reasonable to call 911. Again, people can be very confused after their seizures, and it may take different people different amounts of time to get back to their usual state. But if that seems to be prolonged, you should call 911. And also, if it's the person's very first seizure, calling 911 is definitely appropriate, so that they can get evaluated to understand why they had this first seizure. If you've called 911, when the paramedics arrive, you're going to want to share information with them, particularly about how long the seizure lasted, as well as a description of what you noticed during the seizure. So that is seizure first aid in a nutshell, and that's really all I wanted to talk about today. So I'll hand it over to Elaine.
Thanks, Alice. Thank you again for that wonderful overview of seizures and epilepsy basics. And what I'd like to do is encourage everyone to continue to engage with the Epilepsy Foundation as a support for learning and to help answer any questions you may have. The foundation offers online learning on epilepsy.com, including professional learning and learning for your patients and their families. Online learning and connecting is also available on our End Epilepsy website. And you can visit endepilepsy.com to hear the stories of people living with epilepsy and to see the amazing work of local communities across the country in support of families with epilepsy. You can also find ways that you can become involved with the foundation and the movement to end epilepsy. I also want to share with you our 24/7 epilepsy helpline is available for you to call in with questions about resources and supports, both local, state, and federal resources that are available for your both for yourself and for patients. We can also help to link you to epilepsy centers and specialists in your area. I want to remind everyone that Module 2 in this learning series will take place next Wednesday at noon Eastern Time, and we will review special treatment considerations for older adults living with epilepsy, and there'll be a more extensive discussion about medications and their use, their selection, interactions with other medications. So tune in for that if possible to learn more about treatment considerations in older adults. And finally, I'd just like to say thank you again to Dr. Alice Lamb for guiding us through today's learning. Thank you to everyone online for your participation today. We hope you'll continue to join us throughout this educational series to learn more about epilepsy treatment, the risk seizures can bring, and the impact of epilepsy on older adults who you care for. Many thanks for joining us today and for all you do to care for older adults living with epilepsy. Have a great day, everyone.